I think perhaps what I want to actually talk briefly also is about the importance of bone health agents. So when I think of bone health agents, I remind the group of two important things. Prostate cancer loves to spread to the bone. It's a bone tropic disease. The treatments that we use lead to bone loss. Remember, if you put me on androgen suppression therapy at 51, for a year, I probably will have a significant increase in bone loss, bone mineral density. It's around 5 to 7% per year. So this is real. And thirdly is the fact that most of our men with prostate cancer are elderly, so we men start losing bone density in the 32s, 35s, maybe 40, right? So what happens is as we get older, we start developing osteopenia, osteoporosis. In addition to that, we have a disease that actually loves to go to the bone. We have agents and treatments that are effective, but also can actually lead to further bone loss. So that's a complication, right? So the three things together, are leading to significant issues. So when you think of bone health and the importance of bone health, I think of three buckets. Patients who are needing to be on androgen deprivation therapy for long term, but do not have metastatic disease, and specifically I would argue, not metastatic castration-resistant prostate cancer, right? So metastatic castration sensitive or biochemical recurrence, men who start androgen deprivation therapy. The goal for those patients would be to minimize the risk of bone loss, to minimize the risk of developing osteopenia, osteoporosis, and pathological fractures related not to cancer, but related to, the effect of low testosterone levels. The second bucket is, can we use, bone health agents or bone targeted agents in people with M0 CRPC, meaning men who don't have metastatic disease objectively visualized in imaging technology, whatever imaging technology one may use. And can we use those agents as an anti-cancer effect, if you will, to delay the presence of bone metastasis and maybe even improve outcome? And the third bucket is perhaps we have the bulk of the data, which is in men with metastatic castration-resistant prostate cancer with bone metastasis. So let me address the frontline pocket. So if you look at actually the importance of ADT in the management of men with advanced prostate cancer, again, we talk about bone loss. So the goal would be for us to lead to bone prevention rather. So when you do that, the existing agents that we have used, oral bisphosphonates, IV bisphosphonates, I think the phase 3 data that we have, would certainly support the use of zoledronic acid, perhaps the RAN ligand inhibitor, denosumab, in the context of the best data for those patients. I think the important part is, however you decide which agent is fitting your practice and your patient, it is important to recognize that there are agents that can be given to patients to minimize bone loss, right? Not to delay prostate cancer, not with the intent of decreasing the skeletal related events in that context, because those patients don't have symptomatic progression or radiographic progression. The second bucket is, can we use, bisphosphonates and or RAN ligand inhibitors for patients with M0 CRPC? That is the actually genesis of couple trials, right? So this is the trial that actually Dr. Matthew Smith published many years ago in JCO that has in fact been used as sort of the key PSA doubling time feature to develop, agents in the M0 CRPC. That data with zoledronic acid actually was aborted because the primary endpoint couldn't be met at the time. But yet, some people still believe in the use of zoledronic acid in that context. There was a trial looking at denosumab against placebo for people with M0 CRPC with the goal of delaying rPFS and survival improvement. I can tell you that using denosumab did delay rPFS by 3.4 months. However, there was no survival improvement. And to my understanding, maybe that was the reason why that agent was not FDA labeled in that space. However, if you have patients with M1 or metastatic castration-resistant prostate cancer with bone metastasis, there is plenty of data to use bisphosphonates and RAN ligand inhibitors to decrease the likelihood of one developing a skeletal-related event, again defined by pathological fractures, spinal cord compression, need for radiation therapy, and need for orthopedic surgery. So we have plenty of data. We have the what we used to call the SOMETA 039 trial of placebo versus a low dose of zoledronic acid of a higher dose. And that data demonstrated that zoledronic acid given to patients on a monthly basis did actually delay in a significant manner, skeletal related events. And for many years, that's what we used to do. Then we used then denosumab, and denosumab was actually compared to zoledronic acid in a sort of very unique trial fashion. This was a trial, a phase 3 trial that was already published, obviously looking at a non-inferiority design to demonstrate that denosumab given to the same patient population was not inferior compared to zoledronic acid for SRE prevention. Now, within the same trial, statistically, there was built a superiority design, which means that if the trial met the non-inferiority boundary, then they will proceed to test for superiority. Not only the denosumab was not inferior, but it met also the superiority definition, right? So to me, that data is what I counsel patients with to tell them that the denosumab becomes, for me, is the standard of care, for bone health agent in the castration metastatic setting. And the goal, yet again, is different, is to delay skeletal related events. I think the caveat with where you use zoledronic acid based upon payers or clinical practice model or care pathways or denosumab, I think the important part is we have compelling data that bone health agent is of paramount importance to our patients, not only for bone loss prevention, minimizing the risk of osteopenia, osteoporosis, but also for us to minimize the risk of someone developing skeletal related events, which is something that we tend to see quite a bit when we use a lot of all the old ADT, the new generation oral agents, in fact, all these class of radiopharmaceuticals as well. And we don't know if one leads to another one, but clearly, because of bone tropic issues with prostate cancer and the significant risk of developing SREs, most men, if not all men, with metastatic castration-resistant prostate cancer with bone metastasis should be on a bone health protecting agent. I think that oftentimes the biggest question is, how do you do it? And I think that if I had a patient getting systemic chemotherapy every 3 weeks, I would probably not put the patient on zoledronic acid or denosumab every 3 weeks. I just probably will do it every other time, even though that would go against sort of the published data, if you will. The Europeans have data using zoledronic acid every 3 months for breast cancer for that matter. So I think that most people in practice will keep the patient on a bone health agent. And I think the decision as to how often you do it, you can follow specifics of the trial and do it like that, straight prospective, validated level 1 evidence, or you can adapt your practice and maintain the patient in a different scheme. I think the important part is just to make sure that you follow the patient also for side effects, because there are unique side effects to bone health agents, right? With zoledronic acid, you can have a little bit of flu-like symptoms, you can have a little bit of issues with renal dysfunction, and also obviously the concerns for osteonecrosis of the jaw or ONJ. With denosumab, you don't have the issues of renal dysfunction. You don't have, in my opinion, so much issues with flu-like symptoms, but you also have issues with ONJ as well, and hypocalcemia, which are important for us to pay attention to. It is also very important for you to remind patients in any given setting in disease state in prostate cancer of the importance of smoking cessation, active and vigorous weight-bearing exercise, because that allows you to build bone mass, right? Healthy diets, consumption of caffeine and carbonated substances, and also obviously vitamin D and calcium supplementation for a significant number of these patients. So those are usually what I talk to my patients from the conception of their disease, and throughout their natural history, I start just adapting based upon their needs and based upon where their disease states are.